So thanks everyone for coming. This is the dissertation defense from Denis Schmiernoff. And just to say a few words about Denis. So Denis came to us after he got a Bachelor of Science degree at the University of Washington. And actually, he either got 2 degrees or he was a double major. I'm not sure which. But his degrees, undergraduate degrees, were in biochemistry and in neurobiology. And he's been a graduate student. He's actually in the medical student training program. So he's going for an MD PhD, and this is the PhD portion of his training that is culminating today. And I can't believe it's been 4 years that Denis has actually been working with us, but I would just like to say he's been really an outstanding graduate student the entire time that he's been here. I really expect to see big things out of Denis in the future, and am happy to help his career as it moves forward. Hopefully his research won't get rusty over the next 2 years while he's being a doctor. And I see Denis really as being a person who would definitely be a MD PhD in the true sense of the word, who hopefully will always continue to do research, since I think he's done so well in that arena. So that's just a brief introduction about Denis. Just procedurally, what we'll do is Denis will make a presentation of all of the work that's in his dissertation. We'll then open it up for any questions from the general audience. After that, then we'll have a closed session where it will just be Denis with his committee members, who will then ask additional questions of Denis. We'll then ask Denis to step into a Zoom room on his own while the committee discusses him, and then we'll call him back in once we have a result to tell Denis. So I'll let you take it away now. So the title of his dissertation is Clinicopathological Studies of Alzheimer's Disease and Related Dementias. So Denis, go ahead.
Thank you, Dr. Salmon, for the very kind introduction. As hopefully most of you know, since you're here, my name is Denis Smirnov, and I will be presenting my thesis on the clinicopathologic studies of Alzheimer's disease and related dementias. So first, let us start with what dementia is. Dementia is a clinical syndrome of acquired global cognitive impairment that's severe enough to significantly interfere with one's usual daily functioning. It's a leading cause of morbidity and mortality in the elderly, with current estimates suggesting that nearly 50 million people worldwide currently suffer from dementia, with 1 in 3 seniors dying with dementia. As the population ages, these cases are expected to balloon to over 152 million, or slightly larger than the current population of Russia, where I was born. There are multiple distinct causes of dementia, many of which we'll be discussing here today. But unfortunately, there are currently no disease-altering therapeutics for the vast majority of these causes of dementia, which would actually alter the biological course of disease. Alzheimer's disease is the single most common cause of dementia in the elderly, with a usual age of onset between 60 and 90. There is an exponential increase with ages of onset, across these ages of onset, beginning with approximately 1 to 2% in those age 65 and doubling every 5 years to over 30% in those 85 years or older. Cases with onset before age 60 do occur, though they're relatively rare and account for approximately 6% of all AD cases. There's a range of known genetic influences on Alzheimer's disease, the most dramatic of which is a series of autosomal dominant mutations known as familial AD, that result in near guaranteed onset of the disease in a patient's 30s, 40s, or 50s. However, these are exceedingly rare and account for less than 0.1% of all Alzheimer's disease. For the remaining 99.9% of Alzheimer's, that's referred to as sporadic Alzheimer's disease, meaning non-familial, the major genetic risk factor that's known is the apolipoprotein E4 allele, which confers a 3-fold risk for Alzheimer's disease in those who are heterozygotes and a 10-fold risk for those who are homozygotes. Beyond ApoE, there's a range of other genetic influences with small effects that have recently been combined into what are known as polygenic or risk or hazard scores, which further improve prediction of the likely disease onset. Before we get further into mechanisms, let's start with a little bit of history. The first clinical description of what's now known as Alzheimer's disease was published by Alois Alzheimer, a German psychiatrist and pathologist, in 1906. He described the case of Augusta D., this woman in the middle, a 55-year-old woman with a 5-year history of progressive decline in memory, language, and behavioral disturbances. At autopsy, Alzheimer observed miliary foci and fibrils in her brain, which we better know as amyloid plaques and tau tangles today. At this time, AD didn't garner much research attention and was considered a rare cause of pre-senile dementia, that is, dementia occurring before the age of 65. However, starting in the late 1960s with the work of Blessed, Tomlinson, and Roth, that brought attention back to AD when they showed that many cases of senile dementia, that is, with an onset after 65, had the exact same pathologic changes that were found in Alzheimer's disease. Importantly, they showed for the first time a direct relationship between the degree of Alzheimer's disease pathology and the severity of cognitive impairments in their patients. This work was summarized in a landmark editorial in 1976 by Robert Katzman, arguing that the highly prevalent senile dementia had an indistinguishable clinical syndrome and identical pathology at autopsy to Alzheimer's disease. He wrote, "Neither the clinician, the neuropathologist, nor the electron microscopist can distinguish between these two disorders except by their age of onset." This revelation revolutionized the field of neurology and reclassified Alzheimer's disease from an obscure cause of dementia to the fourth leading cause of death in the elderly. AD is still formally characterized by the same two abnormal protein deposits identified by Alzheimer over 100 years ago now. There are first extracellular plaques composed largely of aggregated beta amyloid protein, and then there are these intracellular neurofibrillary tangles composed largely of hyperphosphorylated tau protein. The buildup of these aggregates is associated with neuronal death and atrophy of the associated structures, which can be seen here on the right. We can see atrophy of all gray matter structures, especially here in the medial temporal lobe, that result in sulcal widening and dilation of the ventricular system, which we typically see in Alzheimer's disease. This buildup of pathology is believed to be progressive, beginning with the deposition of amyloid in neuritic and diffuse plaques throughout the neocortex in the preclinical stages of disease before overt symptoms. This is followed by tau, which progresses in a stereotyped pattern from the medial temporal lobe to broader frontotemporal and parietal cortices. This progression is generally staged with the Brock staging scheme, which we'll be referring to throughout this talk. As the deposition of tau pathology is more closely related to neuronal death, it's not surprising that the progression of tau pathology is also more closely related to the cognitive impairments of the patient. These cognitive impairments first manifest as mild impairments in a patient that do not yet notably interfere with their activities of daily living. This stage is known as mild cognitive impairment, or MCI. In Alzheimer's disease, the first cognitive symptoms resulting in MCI are generally those in memory, as the tau pathology begins in medial temporal lobe structures associated with memory formation. However, there are atypical presentations of Alzheimer's disease that occur with non-memory symptoms, and we'll loop back to these in the second half of the talk. While AD is the most common cause of dementia, over 60 distinct etiologies have been described, and the number of the most common ones have been shown to have both independent and synergistic effects on dementia. This graph on the right may look extremely complicated, but it's one of my favorite pieces of research and shows the various pathologies that can transmit the effects of age to dementia. Here in the middle is all of the AD pathology with various plaques and regional tangles that can interact to contribute to dementia in a patient. The second most common pathology associated with dementia is Lewy body pathology down here. While Lewy bodies in the brainstem are generally associated with Parkinson's disease, Lewy bodies in limbic and neocortical regions have been shown to have a clear association with dementia. Next, we have hippocampal sclerosis, which is a pathology that's been described in the oldest old with neuronal loss and gliosis of certain sectors of the hippocampus that can also clearly result in dementia by itself. Recent work has suggested that hippocampal sclerosis is often associated with abnormal deposits of the protein TDP-43. However, models like the one here on the right show that there are both combined and independent contributions of both of these pathologies separately to dementia. Next, along the top here, we have vascular pathology. Vascular dementia is believed to be a major cause of cognitive impairment and is a common clinical diagnosis. However, due to the variability of the vascular lesions across individuals, the relationship between the vascular lesions and clinical presentations is often relatively weak, and AD pathology is actually often found as a contributing or even sole etiology at autopsy of these patients. Finally, not shown on the graph on the right, but we also have a constellation of rare pathologies collectively known as frontotemporal lobar degeneration, or FTLD, that can also result in dementia. These often present with atypical cognitive and behavioral features and often have a relatively early age of onset between 40 and 65, though there's substantial overlap with the younger cases of Alzheimer's disease, posing a challenge for differential diagnosis. It's also really important to realize that multiple pathologies are not uncommon in the brains of the elderly. In a study of individuals over the age of 90, here on the left, while AD dementia was the single most common pathology in those who died with dementia in this study, the plurality of subjects actually had mixed dementia, mixed pathologies at autopsy responsible for their dementia. And in a study here on the right, we see that over half of all pathologically confirmed cases of AD had at least one concomitant other pathology, most often vascular disease or Lewy body disease here. This all becomes extremely important for the clinical diagnosis of patients with dementia. This has become increasingly important as disease-modifying therapies targeting these underlying protein aggregates continue to make progress in clinical trials. While biomarkers have been developed for Alzheimer's disease, there's currently no definitive way to diagnose these non-Alzheimer's pathologies during life, and autopsy remains the gold standard for this diagnosis. This makes targeting these populations for clinical trials during life difficult and error-prone. And even for AD trials, where an Alzheimer's biomarker can be used as an inclusion criteria, no biomarkers can rule out the presence of other concomitant pathologies that may influence progression or response to potential treatments. Given the lack of biomarkers for many of these non-AD causes of cognitive impairment, it's important to identify unique patterns of clinical and cognitive deficits that might provide clues to this underlying etiologies. The disruption of specific neuronal structures and circuits unique to each pathology should manifest in distinct and identifiable patterns of cognitive impairments that could help distinguish among these similar dementia syndromes during life. However, it is essential to tie the clinical presentation to the pathologic ground truth, since describing the features of a clinically diagnosed group will simply identify many of the same features that were used to make the diagnosis in a circular fashion. Further, certain pathologies, such as hippocampal sclerosis, do not currently have clinical criteria for their diagnosis and are nearly universally misdiagnosed as Alzheimer's disease. Thus, clinicopathologic studies that define pathologies independently of the clinical context allow an unbiased description of the clinical phenotypes that could be used to devise more accurate clinical criteria. And that's exactly what I'm going to be showing you today. I'm going to present a series of studies in which we characterize the clinical and cognitive differences between several pathologies that contribute to dementia. First, we're going to examine the profiles of cognitive trajectories of patients with hippocampal sclerosis and those with Alzheimer's disease, or those with both pathologies, and examine the differences that may aid in clinical differentiation of these pathologies during life. Next, we will examine the clinical profiles and cognitive trajectories of two groups of patients with Lewy body pathology and those with Alzheimer's disease, and to demonstrate differences between the groups that are essential to consider when designing clinical trials targeting these populations. Finally, we're going to present a pair of studies that examine the age-related heterogeneity in clinical and cognitive presentations of autopsy-confirmed sporadic Alzheimer's disease, and show that Alzheimer's disease itself may present with atypical clinical and cognitive features in early onset. We further show that these atypical presentations in early onset occur in the absence of concomitant pathologies and are more related to the distribution of limbic to neocortical Tango pathology. But first, let's start with the first study entitled The Trajectories of Cognitive Decline Differ in Hippocampal Sclerosis and Alzheimer's Disease. This was published in 2019 in the Neurobiology of Aging. As I mentioned before, hippocampal sclerosis is a pathologic cause of dementia in the oldest old individuals. While the prevalence of hippocampal sclerosis begins to rise much later than Alzheimer's disease, it's been suggested that in individuals over 100 years of age, hippocampal sclerosis may actually be more prevalent than AD. Hippocampal sclerosis, or HS, is defined by cell loss and gliosis in the CA1 sector of the hippocampus, the dentate gyrus, and the subiculum, out of proportion to any concomitant AD pathology. Comparing an individual with hippocampal sclerosis here at the top compared to one with Alzheimer's disease at the bottom, we can clearly see more dramatic neuronal dropout, global atrophy, and neurofibrillary rarefaction than we do even in Alzheimer's disease. Clinically, however, there's no good characterization of hippocampal sclerosis, with hippocampal sclerosis often referred to as an AD mimic, and currently no clinical criteria exist to diagnose hippocampal sclerosis or distinguish it from Alzheimer's disease. So that was the goal of this study, to characterize the clinical and cognitive profiles of individuals who went on to have either hippocampal sclerosis, Alzheimer's disease, or both pathologies at autopsy. We selected our sample from the brain bank of the Ucsd Alzheimer's Disease Research Center, which has collected the brains of over 1,000 individuals over the last 30 years. We identified participants with at least one of the two pathologies we were studying and eliminated any concomitant pathologies that may also contribute to cognitive impairment, like I was talking about in the intro, including FTLD and Lewy body pathology. We required that our subjects' last clinical evaluation be within 4 years of autopsy to more comfortably draw associations between the two, and required at least 2 annual visits in order to examine the longitudinal progression of the patients with these two conditions. These final groups resulted in 195 patients with pure Alzheimer's disease pathology, 21 with hippocampal sclerosis, and 18 with both pathologies. As expected, the hippocampal sclerosis patients were generally older at the last visit and at death. However, the groups were generally well matched on education and sex. AD pathology was defined by the NIA Reagan criteria, wherein Brock stage 5 or 6 with moderate to severe neuritic amyloid plaques corresponds to a high likelihood of AD. Thus, by definition, all of the AD groups had either Brock stage 5 or 6. However, note the 2 hippocampal sclerosis patients also had high Brock stages. However, these patients did not have enough amyloid pathology to qualify as Alzheimer's disease. Having defined the groups, we looked back at the existing clinical and cognitive data that has been collected at the UCSD ADRC over the last 30 plus years. The participants in the ADRC undergo annual evaluations that include an interview with both the patient and an informant, a review of medical history, as well as a physical evaluation. They undergo a detailed neurologic evaluation, as well as standardized assessments of functional impairment with the scales like the POD, as well as global cognitive function with measures like the mini mental state exam or the dementia rating scale, or DRS here. Additionally, the patients undergo a more extensive neuropsychological battery administered by a psychometrist that includes multiple tests assessing each cognitive domain. Finally, a consensus clinical diagnosis is reached by the clinical core of the ADRC. Here we can see that in upwards of 80% of each group, the clinical diagnosis was probable or possible Alzheimer's disease, consistent with the classic misdiagnosis of hippocampal sclerosis as Alzheimer's disease. Our primary analysis in the study focused on modeling the cognitive decline over the last 5 years of evaluations leading up to the last ADRC evaluation for these subjects. So let's begin with the global measures of the mini mental state and the DRS. The DRS, being a longer 144-point test, can be broken down into several subscales, including attention, initiation, construction, conceptualization, and memory. The data up here in panel A shows the percentage decline per year on each of these scales, while the figures show the average trajectories for the groups. We can clearly see here that 5 years from the last evaluation on the left of each of the plots, all of the groups are approximately equally impaired. However, the hippocampal sclerosis group in blue declines more slowly on nearly all of these measures and results in less impairment by the final evaluation compared to the other two groups. This is true for all of these measures analyzed, except for DRS memory, which declined at a comparable rate in all of the groups, but hippocampal sclerosis was generally less impaired throughout, both the 5 years out and at the last evaluation. We extended these methods to look at other neuropsychological tests from the cognitive battery on which enough data was available for longitudinal modeling. We observed, again, a generally slower decline here on memory tests on 2 separate wordless learning tests. Interestingly, though, we didn't observe any differences on any of the 5 executive function tests that we examined. We did, however, observe slower decline on language measures that assessed an individual's ability to name words that began with a certain letter, or to name objects that appeared in pictures shown to the participant. It's worth noting that this Boston naming test was the only measure in this entire study that showed a difference between the AD and the combined AD plus HS group in red. In conclusion, in this study, we found that hippocampal sclerosis is indeed an AD mimic, demonstrating similar patterns of global cognitive impairment, albeit at a slower rate of decline than Alzheimer's disease. This means that hippocampal sclerosis remains extremely difficult to identify clinically. There appear to be no major cognitive differences and no biomarkers to help identify HS at this point. While hippocampal atrophy has been suggested to be more quantitatively severe in hippocampal sclerosis than AD, it's qualitatively rather similar on MRI, limiting the utility in differentiating the two. Also, recently, it's been suggested that FDG PET hypometabolism, in the absence of AD ruled out by a biomarker, may be an indicator of hippocampal sclerosis. This has yet to be replicated and also has limited applicability, given that we saw that hippocampal sclerosis often co-occurs with Alzheimer's disease. Another recent development that's been discovered is that hippocampal sclerosis mostly occurs in the presence of atypical TDP-43 pathology. TDP-43 pathology usually presents with abnormal nuclear to cytoplasmic translocation of this protein. This TDP-43 pathology will come up again later in this talk and can also occur in the absence of hippocampal sclerosis and sometimes occurs alongside AD pathology as well. As such, a recent guideline from a working group published last year entitled a new entity called Limbic Predominant Age-Related TDP-43 Encephalopathy, or LATE, which is defined by staging the progression of TDP-43 pathology independent of hippocampal sclerosis. This is all very new, so a lot of future work will be needed to dissect the complex relationship of TDP-43 and hippocampal sclerosis and identify the clinical features that are associated with each pathology, both separately and in concert. But with that said, let's move on to the second study that I'm going to tell you about today, relating to Lewy body disease, entitled Cognitive Profiles Differ in Parkinson's Disease Dementia and Dementia with Lewy Bodies. This study was published last year in the journal Neurology. As I mentioned in the intro, Lewy body disease is the second most common cause of dementia, the second most common pathology associated with dementia. Lewy bodies are these intracellular eosinophilic inclusions that were originally discovered in the brainstem nuclei of Parkinson's disease patients and are believed to be responsible for their motor symptoms. However, Lewy bodies in limbic and neocortical regions have been shown to result in dementia and can occur through two separate pathways. First, Lewy bodies in Parkinson's disease patients and patients with long-standing Parkinson's disease can spread to the neocortex and result in dementia, in which case this is referred to as Parkinson's disease dementia. Alternatively, cognitive symptoms that precede or occur independently of any motor symptoms at all are referred to as dementia with Lewy bodies in this case. A one-year rule separates these two, with Parkinsonism having to have begun at least a year before cognitive symptoms to be classified as PDD rather than DLB. Together, these two pathologies are referred to as Lewy body dementia and share common core clinical criteria. These include spontaneous Parkinsonism, even in the absence of full-blown Parkinson's disease. Additionally, these patients are more prone to have visual hallucinations and fluctuations in cognition. A recent revision of the criteria also added REM sleep behavior disorder, or RBD, which is a parasomnia that involves patients performing complex motor movements that can sometimes be violent and sometimes involve acting out the patient's dreams. Due to the qualitatively similar pathology in these two conditions, as well as the common clinical symptoms they share, and the kind of arbitrary nature of the one-year rule I described, there's been considerable debate in the literature as to whether DLB and PDD should be considered a single entity or if they should continue to be separated. Our study is designed to address this from a cognitive perspective, to evaluate if there are meaningful differences in the cognitive trajectories of patients with DLB or PDD. However, another important consideration is the presence of concomitant AD neuropathology in Lewy body cases. It's been reported that 20-25% of all AD cases have concomitant Lewy body pathology. And the degree of AD pathology in Lewy body cases is a major determinant of the patients exhibiting a typical DLB profile. This table below shows just that. It shows the likelihood of presenting with a typical DLB profile clinically that we described on the previous slide, given their pathology. On the left, we can see the stages of Lewy body pathology, and we can see that the earlier stages in the olfactory amygdala or brainstem, Lewy body pathology does not typically result in the typical dementia syndrome of DLB. However, neocortical and limbic Lewy bodies often do. However, along the top here, we see the degree of concomitant Alzheimer's disease pathology. We can see that as the Alzheimer's disease pathology increases to the right, the probability of presenting with the typical Lewy body profile rather than an Alzheimer's-like profile decreases. This poses a significant challenge for accurate clinical identification of DLB cases, meaning that autopsy is once again our gold standard to define the ground truth pathology. It's also important to note that AD is more likely to co-occur in DLB than PDD, which may influence the clinical profiles of these two patient groups. With that said, let's move on to the present study, where we compared the clinical and cognitive trajectories of 29 patients with PDD, 58 patients with pathologically confirmed DLB, and 174 patients with pathologically confirmed Alzheimer's disease. Only 12 of the 29 PDD patients had pathologic verification, but the diagnosis of dementia in the context of established Parkinson's disease has an extremely high accuracy of over 90%. These subjects were matched on age, education, and DRS score at the baseline visit, which was defined as the first visit with a dementia diagnosis. This dementia diagnosis was largely Alzheimer's disease here for both the Alzheimer's and DLB group, with only 26% of the DLB group actually diagnosed as DLB during life. This may actually be related, though, to the high percentage, 57%, of DLB cases that had high concomitant AD neuropathology, which we saw on the last slide, may influence the clinical picture. The majority of PDD patients, though, we see didn't have concomitant AD pathology, and all were clinically diagnosed as PDD. So while in the previous study, we analyzed each of the cognitive measures separately, this time we implemented a principal component analysis to identify the underlying cognitive domains that are assessed by these measures. As you can see, we ended up with 4 components along the top, conceptually labeled visuospatial, memory, executive function, and language. This table represents the component loadings for each test for each domain, with the strongest loadings highlighted for you so you can clearly see that we have multiple tests assessing each cognitive domain. Using the raw test scores and these loadings, we're able to calculate a subject's performance in each domain, which we then scaled into a z-score relative to performance of robust normal controls, which were ADRC participants who remained cognitively normal for the duration of their ADRC participation, which averaged approximately 5 visits. Here we start with the baseline cognitive domain performance at a time when the 3 groups, AD, DLB, and PDD, were matched on global cognitive measures on the MMSE and DRS. We can see that the visuospatial domain was more impaired in the 2 Lewy body groups, which is a classic finding for Lewy body disease, where it's just known to be more visuospatially impaired than AD patients. We also see this stepwise double dissociation, where AD patients were more impaired on memory than DLB, and both groups were more impaired than PDD, and the opposite pattern in executive function, where PDD was more impaired than DLB and more impaired than AD. There were no cross-sectional differences in language. Next, we used mixed effects models to examine the 2-year longitudinal trajectories of decline of these domains and observed a generally consistent pattern. Visuospatial ability and executive function declined more rapidly in the Lewy body groups than in AD, with executive function declining even more rapidly in PDD than even DLB. Language decline was more pronounced in AD and DLB and rather minimal in the PDD group, while memory declined in parallel in the 3 groups, though PDD was generally less impaired than the other 2 groups. So clearly now we see that there are some differences between the profiles of decline of DLB and PDD. But what does this actually mean in practice for these conditions? We wanted to answer this question by demonstrating what would happen in a hypothetical clinical trial with a therapeutic targeting Lewy body disease that may be applicable to both DLB and PDD patients. Here we performed MMRM power calculations to estimate the number of participants that would be needed to detect a 50% reduction in decline under 3 conditions. First, we had a combined group of 1-to-1 DLB and PDD patients pooled together. Next, a group of pure PDD patients, and finally, a group of only DLB patients. Since these patients differed in their domain-specific trajectories, we examined what would happen if the primary outcome measure in the trial targeted specifically each one of these cognitive domains along the top. So let's take a look at language over here on the right as an extreme example. We can see that in the combined group, you would need 58 participants per study arm to have 80% power to detect an effect if language was your outcome measure in this trial. However, if we chose the PDD group by itself, we saw the PDD barely declined at all on language over 2 years, making it hard to see any effect, suggesting that you would need over 800 participants with PDD to be able to detect a 50% reduction in decline. The DLB group, in contrast, declined far more, and you would only need 33 participants in this case to identify the same change. We can see a very similar pattern in memory, where while the groups declined at comparable rates, there was a lot more variability in the decline of PDD patients, meaning that more than double the number of patients would be required in a PDD group than a DLB group. This is particularly important since a lot of the outcome measures in general clinical trials tend to target memory. Next, since PDD declined more rapidly than DLB on both visuospatial and executive tasks, we can see the exact opposite effect, where far fewer PDD patients would be needed to detect a reduction in decline than either patients with only DLB or the combined one-to-one group. Overall, this work suggests that while DLB and PDD may share a lot of clinical features, there is a clear benefit to continuing to separate these diagnoses, at least for the purposes of clinical trials and prognosis. So overall, in the study, I've shown that both DLB and PDD have dissociable cross-sectional cognitive profiles and trajectories of decline in a domain-specific manner. We know that this may be complicated by the greater presence of AD pathology in the DLB than PDD groups, possibly resulting in the more AD-like cognitive profile we saw with memory and language impairments. Future work really should focus on separating out the effects of AD tau pathology and alpha-synuclein Lewy body pathology within DLB. But for now, let's move on to our final set of studies, the third and fourth studies, talking about the neuropathologic basis of the age of onset-related heterogeneity in Alzheimer's disease. The first of these studies was recently accepted to neurology, while the second was submitted to Acta Neuropathologica yesterday. So while the concept of separating senile and pre-senile dementia, as I was talking about in the intro, has fallen out of favor in the scientific community, there's still significant evidence that the age of onset of symptoms in AD can have a marked impact on the clinical presentation. And those patients with early onset are more likely to present with atypical features. These include a delay in diagnosis from when symptoms are first noticed compared to individuals with later onset. Patients with early onset also exhibit a faster cognitive decline with a more rapid disease course and more rapid deterioration of cognitive abilities. They're also more likely to present with non-memory symptoms as their first reported deficit, and these include behavioral disturbances as well as issues with language, visuospatial abilities, or executive function. Relatedly, they are more likely to meet clinical criteria for focal cortical syndromes, including primary progressive aphasia, posterior cortical atrophy, or behavioral variant FTD. All of these atypical features, in turn, complicate the differential diagnosis and make these early onset patients more susceptible to misattribution to non-AD etiologies clinically. However, there's pretty limited understanding of what underlies this heterogeneity. Most of the studies done looking at the age of onset differences were done without autopsy verification, meaning that the most atypical cases of Alzheimer's disease were likely misdiagnosed as non-Alzheimer's and eliminated from these samples. Additionally, while Alzheimer's can be confirmed with biomarkers, it remains impossible to characterize the contributions of concomitant pathologies such as Lewy body disease or hippocampal sclerosis without autopsy verification. As such, this first study was performed with pathologic data from the National Alzheimer's Coordinating Center, which is a large database collecting clinical and pathologic data from over 30 Alzheimer's centers across the country, including ours. We used data from 1,750 participants with pathologically verified severe Alzheimer's disease, defined again by the NIA Reagan criteria as Braak stage 5-6 with moderate to severe neuritic plaques. Since our focus here was on sporadic Alzheimer's disease, again, non-familial, we eliminated anyone with a known history of a familial mutation or those with ages of onset before the age of 50. Next, we examined the distributions of age of onset by ApoE genotype. This plot in the top right shows just that. And we can see that these are distributions of the ages of onset by ApoE genotype smoothed across age of onset on the x-axis. We can see the generally expected pattern of earlier ages of onset peaking with increasing numbers of this E4 risk allele. However, if you look at this green distribution, we notice a bimodal distribution with the second peak in early onset accounting for about 25% of these participants. Intrigued by this, we used the mixture model analysis to identify age 63, this gray dashed line, as the age that best separates the two age of onset components, and used this age 63 cutoff to classify all of our patients into either early onset or late onset disease. Since we were particularly interested in this early peak of individuals without an ApoE allele, we also examined the effects of the ApoE genotype and the interaction of ApoE genotype with age of onset on clinical, cognitive, and neuropathologic outcomes in NAC. While the study participants were all analyzed in this 2x2 design of early versus late onset and E4 plus versus E4 minus, with covariates for sex and education where appropriate, the tables here are show group demographics for illustrative purposes. We start on the left with the 2 late onset groups and the 2 early onset groups on the right with their respective ends. Next, we have the effect of being early rather than late onset with this 99% confidence interval, followed by the effect of having at least one E4 allele, and when significant, the interactions of early onset with E4, which are particularly interesting in the context of this study. We can see that late onset cases are by definition older than early onset cases, but interestingly, early onset cases tended to have a slightly longer duration of disease by about 0.8 years. We also saw that early onset cases were more likely to be male, and as one might expect, ApoE genotype was related to increased family history of dementia. However, strikingly, this strange early onset E4 negative group that we're interested in had the lowest rate of family history of dementia, suggesting that these are not just cases of missed familial Alzheimer's disease without a history. We first looked at the presenting symptoms reported by the patients in each group. In each of these plots, the bar represents the total number of patients in the group, and the proportion colored with each color corresponds to what the first cognitive symptom was. You can see on the left, the vast majority of these bars are orange, corresponding to cognition being the first symptom reported. However, this early onset E4 negative group, the third one from the left, shows a slightly higher rate of either behavioral or motor symptoms at onset. On the right, we're zooming in to just the cognition to see which cognitive domain was reported first impaired. And again, as you might expect for Alzheimer's disease, in orange, the vast majority of cases reported memory as the first impairment. However, the 2 early onset groups on the right, and especially this early onset E4 negative group, showed a much greater proportion of individuals reporting visuospatial, executive, or language impairments at onset. Next, we looked at the clinical evaluation and saw that both patients with early onset and those with an E4 allele were more impaired on global cognition by the mini-mental state exam. They were also more impaired functionally by the FAQ and had more psychiatric symptoms measured by the Neuropsychiatric Inventory, or the NPI. On medical history, we observed that those with early onset had less history of stroke and TIA, consistent with the age-related nature of these conditions. However, early onset cases were more likely to report a history of traumatic brain injury. And very interestingly, early onset cases were much more likely to report a history of depression, either in the past 2 years or older than that. The significant interaction here for depression suggests that this strange early onset E4 group actually had the highest rate, disproportionately higher rate of depression than any of the other 4 groups. Just like in the previous study, we used principal component analysis to generate cognitive domain scores for our participants. However, note that the Adrc neuropsych battery is much more extensive than the one available in NAC, so the NAC one is rather sparsely populated with fewer tests analyzing each domain. Memory, for example, is analyzed with just the logical memory immediate and delay conditions and from just a single story of the logical memory test. Additionally, there are no good visuospatial measures in NAC, so we were not able to generate a visuospatial component, instead generating an attention component, which largely indexes digit span forward and back. Nonetheless, when we look at the domain-specific baseline cognitive performance, we see some dramatic, clear differences. These are again z-scored relative to robust normal controls. First, there's a striking difference in the degree of executive impairment in the 2 early onset groups compared to the late onset groups on the left. Additionally, there's a significant interaction term suggesting that this early onset E4 negative group was actually even more impaired than the early onset E4 positive group in executive function. In contrast, memory was unaffected by age of onset, but that was worse in those with an E4 allele. Language was generally mildly impaired overall, though slightly less so in those with early onset, while attention was altogether unimpaired, but a little worse generally in those with early onset. Next, we examined the longitudinal trajectories of global cognitive and functional decline by examining the mini-mental state exam and the CDR sum of boxes over 5 years. On both measures, we saw more rapid progression in those with early onset, but there was no E4 effect and no interactions. Next, we examined the clinically assigned etiologies that were believed to be responsible for the cognitive impairment in each group. This plot's a little more complex, but is colored by which etiology or combination of etiologies were assigned to the patient at the last visit at an ADRC before death. The orange bars represent individuals called just AD, with the lighter colors along the top representing combinations of etiologies that included AD. However, these darker colors along the bottom correspond to misattribution of the etiology to non-AD causes, because I remind you that all of these patients were selected to have pathologically confirmed severe AD at autopsy. We can see specifically that cases with early onset were more likely to have their etiologies misattributed to a non-AD cause, and specifically more often to frontotemporal dementia, FTD, in purple here, either in the presence of AD at the top or in its absence at the bottom. However, when we actually look at the pathology, we see a strikingly different picture. On the left, these bars represent the percentage of the groups that had concomitant vascular pathologies. As most vascular pathologies are age-related, we can see the expected effect of fewer vascular pathologies in both of the early onset versus late onset groups. The only exception to this was the amyloid angiopathy, which is tightly linked to AD pathology and was associated with the E4 allele rather than with age of onset. Moreover, on the right here, we can see the combinations of non-vascular pathologies that were assigned at autopsy. Along the top in purple, we can see that approximately 50% of all groups had only AD pathology at death, and another approximately 25% had AD with concomitant Lewy body pathology in blue. However, FTLD pathology in purple was extremely rare in all of the groups, despite the fact that nearly 30% of this early onset E4 negative group had FTD etiologies assigned clinically. Overall here, we can see the paradox that this early onset E4 negative group, which had the most atypical clinical features, actually has the least concomitant pathologies that might explain those. So to wrap up the study, we showed that individuals with early onset AD, and especially those without E4 allele, were more likely to present with non-memory symptoms and demonstrate a stronger dysexecutive profile in objective cognitive testing. They exhibited more rapid cognitive decline and had greater psychiatric involvement as determined by the NPI and a history of depression. And they were more likely to have a non-AD etiology assigned clinically. However, paradoxically, they had the least concomitant non-AD pathology at autopsy. There's a number of explanations that we can propose for this. First, there could be genetic contributions beyond the influence of ApoE that weren't analyzed in the study. However, this seems unlikely given that our early onset E4 negative group had the lowest rates of family history of dementia. It's also possible that psychiatric conditions, such as depression or others, may contribute to the impairment in early onset cases. It's rather unclear if the depression was a cause of impairment or rather a symptom of the diagnosis of dementia at such an early age. This would clearly require further study. Next, we generally didn't observe many concomitant pathologies in early onset cases that could explain the cognitive profiles we observed. However, we analyzed the NAG dataset from over 30 years that didn't include consistent assessment of newer pathologies on all the patients, such as TDP-43. And finally, and most likely in our opinion, the atypical profiles could be due to differences in the distribution of the AD Tango neuropathology itself across ages of onset. The reason we believe the distribution of Tango pathology in AD might be responsible for the atypical features was a publication from 2011 by Melissa Murray and Dennis Dixon, not really focusing on the age of onset thing, but instead describing a mathematical algorithm to classify cases into neuropathologically defined subtypes of Alzheimer's disease. This algorithm compared neurofibrillary Tango densities in the hippocampus to neocortical regions and classified those with high cortical density and relatively low hippocampal density as hippocampal sparing Alzheimer's disease, while those with relatively more hippocampal density and low cortical density as limbic predominant Alzheimer's disease. Strikingly, we noticed that these subtypes differ substantially in their ages of onset, with hippocampal sparing AD showing the youngest onset at age 63, typical AD at 69, and limbic predominant AD at 76. Moreover, these hippocampal sparing cases with the youngest ages of onset were the most likely to show atypical clinical presentations and had the least concomitant TDP-43, vascular, and Lewy body pathology. Finally, these hippocampal sparing cases were overrepresented specifically in the early onset E4 negative group, all consistent with our previous study. So this brings us to the very last study I'm going to be talking about, which involved 121 participants from the Ucsd Adrc Brain Bank. These were all again classified as high likelihood by NIA rating criteria with broad stage 5-6 with moderate to severe neuritic plaque pathology. And again, we excluded autosomal dominant mutation carriers and those with an age of onset before 50 to eliminate individuals with potential genetic autosomal dominant genetic mutations. Additionally, we performed a more extensive neuropathologic evaluation than was available on all of the participants in NAC. Specifically, we performed alpha-synuclein immunohistochemistry to stage Lewy body disease into brainstem, limbic, or neocortical subtypes. We performed TDP-43 immunohistochemistry to stage cases according to the latest LAID guidelines from last year into amygdala, hippocampus, and neocortical subtypes. We had a 4-point severity rating scale for microvascular arteriolosclerosis as a measure of vascular disease. And most importantly, we performed neurofibrillary tango counts in the hippocampus and midfrontal cortex, from which we calculated the midfrontal to hippocampal tango ratio, which will be our most important single measure of relative tango distribution. From these three measures, we also performed an approximation of the Murray et al. Subtype classification. So let's start with the clinical features at baseline, which in this study was defined as the first ADRC visit with a non-normal clinical diagnosis. Here, the participants are binned by their age of onset, and the groups were matched on sex, education, and year of autopsy. Though while the demographics are binned here by group, all of the statistical analyses were performed on age of onset as a linear variable. The major features I want to draw your attention to here are the longer interval from onset to baseline in those with early onset, as well as the same pattern of non-memory presentations that we saw in the previous NAC study. Here, these plots are very similar to the bars we saw in the previous study, except they're now smoothed across age of onset on the x-axis. So those individuals here on the left with earliest ages of onset, we can see were more likely to have either language or visuospatial rather than memory impairments. Next, while the participants didn't differ on global cognition at baseline on the mini mental state exam, those with early onset were once again more impaired psychiatrically on the neuropsychiatric inventory. And finally, once again, those with early onset were more likely to be misdiagnosed as something other than Alzheimer's disease. In this case, specifically, a greater rate of misdiagnosis as Lewy body disease clinically. I'm so confident in saying misdiagnosis here because when we look at the concomitant pathologies, we see that Lewy body disease here on the left was no more common in early onset. These plots show the relative proportions of individuals who had concomitant pathology at autopsy and the stage of that pathology. So here on the left, for example, we can see that approximately 20 to 25% of all cases had one of the three stages of Lewy body pathology, although this did not differ across age of onset. In contrast, both TDP-43 pathology and vascular pathology clearly increased with age of onset. You can clearly see the proportion of individuals without TDP or vascular pathology in orange along the top decreasing as we move to the right. This once again points to the same paradox we saw earlier. The cases with the most atypical clinical presentations tend to have early onset, but the cases with concomitant pathology tend to have later onset, suggesting once again that the concomitant pathologies are not likely to account for the clinical heterogeneity that we're trying to explain here. So let's take a look at our other candidate explanation, the distribution of neurofibrillary tango pathology. As I mentioned, we performed tango counts in the midfrontal cortex along the top and the hippocampus along the bottom here, and calculated a ratio of the midfrontal to hippocampal tangos as a measure of the relative distribution of the pathology. We have two examples here, with the one on the left had strong staining in the neocortex and relatively sparse staining in the hippocampus, giving them a high midfrontal to hippocampal tango ratio and having them classified as hippocampal sparing AD. The case on the right, in contrast, had low cortical staining at the top, but more dense staining at the hippocampus, resulting in a low midfrontal to hippocampal tango ratio, resulting in them being classified as limbic predominant Alzheimer's disease. When we plot this tango ratio across ages of onset, we observe a strong inverse relationship such that those patients with early onset were more likely to have greater tango ratios, that is, a relatively more neocortical tango distribution. To understand what was driving this relationship, we looked at the individual tango densities and saw the same strong relationship of age of onset with the midfrontal tango density in the middle, but no relationship with the hippocampal tango density on the right. Instead, not shown here, but we observed an ApoE effect so that those with an E4 allele had a greater hippocampal tango burden regardless of their age of onset. Here we can plot the two tango densities against each other with hippocampal tango density on the x-axis and neocortical density on the y-axis. I've also colored the points by their ages of onset with red colored corresponding to later onset and blue corresponding to earlier. Finally, I've included the borders here for the Murray et al. Subtype classification. So we can clearly see that those individuals in this quadrant corresponding to hippocampal sparing AD are mostly generally blue, corresponding to early onset. And those in the limbic predominant quadrant over here are generally red, corresponding to later onset. So overall, this all clearly shows that there is a difference in the distribution of NFT pathology by age of onset, with more neocortical pathology in early onset cases that could at least hypothetically explain the atypical clinical profiles we're studying. But we weren't satisfied with just that and wanted to test this formally. So we examined how cognitive performance in 4 cognitive domains, memory, executive, visual spatial ability, and language, differed by age of onset. These scores are once again derived from principal component analysis of the larger ADRC neuropsych battery with multiple tests for each domain, now again including visual spatial tests as the ADRC has better visual spatial measures than the NAC battery. While we can see that memory and language generally didn't relate to age of onset, both executive and visual spatial performance was more impaired in individuals with early onset, consistent with the atypical clinical features we generally see in these groups. Next, we performed a mediation analysis to formally test the hypothesis that the effect of age of onset on executive function was mediated by, that is, transmitted through, an indirect effect of age of onset on the Tango ratio, and in turn, an effect of the Tango ratio on executive function. And indeed, this is exactly what we found for executive function, where there was a significant mediation effect by this Tango ratio. However, this was not observed in the same way for baseline visual spatial ability, where the midfrontal to hippocampal Tango ratio was not a mediator of a significant direct effect of age of onset on visual spatial function. We also tested each of the concomitant pathologies, Lewy body disease, TDP-43, and microvascular disease for their ability to mediate any of these effects either in executive or visual spatial function, and found no mediation effects, again suggesting that these concomitant pathologies are not responsible for this clinical heterogeneity. Finally, we analyzed the longitudinal rates of decline in a series of individual tests for which we had data to calculate 2 to 3 year rates of decline. These annualized rates of decline are now on the y-axis, and we can see that a number of tests, specifically the mini mental state, the total DRS, and all of the DRS subdomains except for DRS memory, were more impaired in early onset. This was actually also true of the category fluency subtest. Further, when we implemented the same mediation analysis approach, we saw significant mediation effects by the midfrontal to hippocampal Tango ratio in all of these measures with an asterisk, that is, all of the ones that had age of onset effects, except for DRS construction, which is once again consistent with the lack of a visual spatial mediation effect that we saw on the last slide. Once again, when we tested the concomitant pathologies, none of them mediated any of these rates of decline. So to wrap up this last 2 studies, we have once again shown that patients with pathologically confirmed severe sporadic Alzheimer's disease at autopsy with earlier ages of onset are more likely to show atypical clinical features with more prominent memory, non-memory presentations, and more rapid decline. However, on detailed pathologic evaluation, these early onset cases actually had less concomitant vascular and TDP-43 pathology. Instead, we observed a greater midfrontal Tango burden, which translated into a higher cortical to hippocampal Tango ratio in early onset individuals. And finally, we showed that this Tango ratio, but not any of the concomitant pathologies, mediated the effect of age of onset on executive function performance and decline, providing direct evidence that the distribution of AD pathology itself is a major determinant of the clinical presentation across age of onset. So there are 2 potential explanations we see for the higher cortical to hippocampal Tango ratio in cases with early onset. Either the neocortex is more vulnerable or the hippocampus is less vulnerable to tau pathology in younger individuals who develop severe AD. The latter option seems more likely given the extensive literature on selective hippocampal vulnerability to ischemia, hypoglycemia, hyperexcitability, metabolic stress, and, well, of course, neurodegenerative diseases with increasing age. So if the hippocampus is less vulnerable In younger patients, while the neocortex is similarly vulnerable, younger onset patients should have a relatively more neocortical distribution of pathology at any stage of the disease. This analysis was restricted to patients with Braak stage 5-6, so severe Alzheimer's at autopsy, due to the extremely low rate of individuals with earlier onset dying with lower Braak stages. However, this may be responsible for our failure to find any contributions of the concomitant pathologies in this sample, which surprised us. These effects were likely overshadowed by the severe AD, but similar analyses in less severe cases may reveal important contributions of these concomitant pathologies. One approach to address this limitation and look in earlier stages of disease would be to use tau PET imaging, which would allow examination of regional NFT distributions at an earlier stage of disease and at a time point more proximal to the clinical evaluation. However, until either PET ligands or biomarkers become available for the concomitant pathologies that co-occur with AD, this approach would once again be limited in its ability to assess the contributions of these concomitant pathologies. Overall, this series of studies has highlighted the difficulty in accurately identifying the underlying etiologies of impairment in dementia. While AD is the most common cause overall, in old age, we showed that the features of AD overlap extensively with hippocampal sclerosis. In contrast, in younger patients, AD shows atypical clinical features that lead to misattribution of the etiology to FTLD or other causes. Biomarkers to rule out AD can aid in this differential diagnosis, and future work should focus on identifying unique features of pathologies once AD is eliminated as a potential etiology. However, we also saw that these pathologies often co-occur, and thus a positive biomarker for AD does not rule out the presence of these concomitant pathologies. In our series of studies, we saw minimal influence of these other pathologies in the context of severe ADs, though. For example, in the first study, the hippocampal sclerosis plus AD group was nearly indistinguishable from pure AD, differing only on a single measure, the Boston naming test. In our second study, we saw that the DOB group was with more concomitant AD pathology than the PDD group also exhibited more AD-like clinical profiles with more prominent memory and language impairments. And in our final two studies, we demonstrated that it was the distribution of AD pathology rather than any of the examined concomitant pathologies that mediated the age-related clinical heterogeneity of AD. Here, future work should focus on examining the contributions of concomitant pathologies in the context of less severe AD, where their influence may be more apparent. And finally, given the overwhelming dominance of AD, it's still essential to further improve the characterization of the heterogeneity that is present within Alzheimer's disease, along age or any number of other dimensions. And with that, I would like to thank all of you for listening to this presentation, and I'd like to take a couple of minutes to thank a couple particular people, starting, of course, with Dr. David Salmon, who's been my closest mentor, someone I meet with almost every single day, who's guided me through this entire process. I honestly don't know how I would have done any of this without him. So much of this is all due to his support, both in science and in life. He's become a mentor and a friend through all of this. A couple other people are Dr. James Brewer, who was the first person and our fearless leader to invite me to the Alzheimer's Center, to find me a place here, to find funding and give me the opportunities to work with all of these wonderful people. And Dr. Douglas Galasco, who also co-leads the clinical core here at the Adrc, has an office right behind my cubicle and has gotten me involved in some of the most interesting projects in biomarkers that I've come across. I'd also like to thank Dr. Edwin, who's been the statistical help for every single project, who's inspired me to learn R and has been such a help with arranging all of these analyses, as well as the two pathologists, Larry Hansen, who's been around for a long time collecting all of the pathologic data that was used in most of these projects, and our more recent addition, Annie Hineker, who has been collaborating with us, especially in this last project, doing a lot of the Tango counts and the extra staining. I'd of course like to thank all of the other co-authors that were co-authors on any of the papers I presented today from the Alzheimer's Center. And since we're running out of time, I'll make this quick. Everyone else at the Alzheimer's Center, all the staff and faculty that weren't necessarily co-authors, but all worked tirelessly to collect all of the clinical data that I once again used from the Alzheimer's Center. I'd also really like to thank my parents who gave up their lives in Russia to come to America to give me and my brother the opportunities to pursue these degrees. I doubt I'd be getting even one doctorate, let alone two, if I had stayed in Russia. And finally, I'd like to thank my pets for the perpetual emotional support, my 2 cats, Kisa and Ink, and of course my Great Dane Pepper, who's been around with me and has encouraged me to take advantage of the many dog beaches of San Diego throughout my time here. And with that, and exactly an hour into this, I'd like to turn to any questions that anyone may have.
Thank you, Dennis, for that terrific presentation. And it really just shows the tremendous amount of work that you were able to accomplish while you were here. So yes, let's open it up if there are any questions from the audience.
Either in person or in chat will be just fine too.
So, any questions from the audience?
Dennis, this is Steve Edlund.
Hi, Dr. Edlund.
I just want to know where you got that picture, and boy, I'd sure like to have a copy of that picture you had on the next to last slide.
Of you? That picture,
Who was that young man?
They're all on the ADRC drive. All of those pictures I scoured from the photo backups of the ADRC drive if you're interested.
Okay.
Dennis, your power calculations were really impressive.
Oh, thank you.
Do you imagine there being some therapeutic implications, or was that a hypothetical study sometime in the future?
No, that was all very much hypothetical for a hypothetical drug, hypothetically applicable to these populations, and all the calculations were done in a very idealized manner. So those numbers are by no means accurate. You would need far more than 33 patients per group in an actual clinical trial. However, this I think demonstrated very nicely the pattern of results. There were these huge differences that could be seen. And if you were targeting Lewy body disease, in my opinion, you should definitely separate PDD and DLB patients and target the appropriate outcome measures to each.
Dennis, can you hear me? This is Annie.
Hi.
This is something I've asked you in private, but I'd like you to address what we could do next with the pathology. Like what would be exciting to do? I know that you're going back to the clinic, but we have a little bit more time. So what are exciting other studies we could think about doing for the early onset?
So, I mean, with this early onset stuff, the most obvious directions to take this are other cortical regions. We only really looked at hippocampus and midfrontal, and we didn't see, the most obvious thing here is that we didn't see a visuospatial mediation effect, which I think we might be able to get to if we looked at regions more involved in visuospatial processing. So if we had Tango counts and other analyses of more posterior regions in parietal and temporal-occipital cortex, I think we may be able to find mediations of those effects. Additionally, like I said, we didn't really find anything in terms of concomitant pathologies, which I thought was a little surprising in the context of this study, but is likely due to the fact that, again, all of these patients were very severe, Brock stage 5, 6, AD. So the other move there would be to look at individuals with less severe AD and see if we see contributions of these concomitant pathologies.
Great. Yeah, I like both of those ideas.
Dennis, this is Paul Insel. This is not my field. As MSDP co-director, I'm really proud of the job you've done today. I thought it was really excellent. But I want to ask you sort of a philosophical question, and this may reflect my ignorance in this area. After listening to you, I'm really struck at the variability, the heterogeneity that exists when one looks at the pathology among the patients. And could it be that really, even though we often talk about being lumpers and splitters in terms of looking at clinical material, whether it be pathology or lab tests, whatever, could it be that every patient is different? In a sense, almost every patient is different, and everything has to maybe be an N of 1 if one wants to think about the pathology together with the clinical features. It just seems there's so much variability. I just wonder what your thoughts are about that.
I mean, I absolutely agree. There's a ton of variability, and that's why I think it's important to look at the differences that can exist, say, within Alzheimer's disease across some of these dimensions. You may have noticed that in one of the first studies, I had dichotomized age of onset and now later moved on to analyzing it as a continuous variable, exactly because I do think that, especially given the prevalence of Alzheimer's disease, a lot of these things are continuums and will differ by individual people. And it's important to consider, for example, there's a lot of interesting work on sex effects in Alzheimer's disease that I didn't really at all address here, but there's a lot of great work going on here. Obviously, effects of age that I saw, there's very well-established effects of education in terms of cognitive resilience and reserve that are being studied. So all of these things obviously interact, but I don't necessarily think it's purely things of like an N of one. I'm sure we can find generalizations that we can draw that are going to be applicable to patients that can improve prediction of an individual's trajectories going forward, some prognosis, and improve how we can tailor clinical trials.
That's encouraging. I'm glad you answered it that way. I hope it's true.
I hope so too.